Hello, everyone. Thank you for joining today's briefing, Recent Trends and Policymaking Impacting Medicare and Medicaid's Home and Community-Based Services. I'm Christopher Holt, Vice President of Policy and Federal Affairs here at the Alliance for Health Policy. For those of you who are not familiar with the Alliance, let me welcome you. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. Today's briefing is brought to you by the generous support of the SCAN Foundation. The SCAN Foundation is an independent public foundation transforming care so that every older adult has a set of choices and the opportunity to age well at home and in community. The foundation emphasizes priority populations that are older people of color, older adults with lower incomes, and older residents of geographically underserved communities. Let me also take this moment to ask you to follow the Alliance for Health Policy on LinkedIn to stay informed about upcoming events like this one. You can also find us on Facebook, YouTube, and Twitter. Today's panel has a Q&A section at the end, and we want you all to be able to be active participants, so please have your questions ready. You should see a dashboard on the right of your web browser that has a speech bubble icon with a question mark. You can use that icon to submit questions that you have for the panelists at any time, and we'll be collecting those throughout the broadcast, and we'll do everything we can to address as many of them as possible during the broadcast. Throughout the webinar, you can also chat about any technical issues that you may be experiencing, and we will do our best to help you with those. Now, I'm very pleased to introduce to you Kayla Holgesh from McDermott Plus Consulting. Kayla is a skilled, passionate health policy professional with experience covering legislation, research, complex policy and data analyses, and strategic planning. Prior to joining McDermott, Kayla served at MacPac, providing information, evaluations, and recommendations on the Medicaid and children's health insurance programs for members of Congress, executive branch decision makers, and state-level leaders. Kayla led MacPac's work analyzing racial and ethnic health disparities among Medicaid beneficiaries and was integral in authoring the organization's public statement committing to combat institutional racism and address racial disparities in healthcare and health outcomes. So with that, I'll pass the baton to Kayla. Welcome.
Thank you so much, Chris, and thank you to the Alliance for having me. I'm very excited to be here and delighted to be moderating today's discussion. So I will jump right in introducing today's panelists. First, we have Amy Bassano. Amy is a senior executive and nationally recognized health policy expert with more than 20 years of experience developing organizational vision and strategic plans, designing and implementing payment systems, and driving change in the healthcare delivery system. Amy joined HMA as Managing Director of Medicare Services after serving as the Deputy Director for the Center for Medicare and Medicaid Innovation, or CMMI, within CMS. As Senior Executive at CMMI, she oversaw the development and implementation of value-based purchasing models for both Medicare and Medicaid, including accountable care organizations, bundled payment programs, and specialty initiatives in oncology, kidney care, prescription drugs, state-based models, and dual eligibles. Additionally, she collaborated with states, health plans, purchasers, and international organizations to lead the national and international movement to value in healthcare. Next, we'll hear from Kate McAvoy. Kate became Executive Director of the National Association of Medicaid Directors in January of this year. NAMD is a professional community of state leaders who provide health insurance to more than 80 million individuals and families through Medicaid and the Children's Health Insurance Program in each of the 50 states and DC and the US territories. NAMD elevates thought leadership on core and emerging policy matters, amplifies the experience and expertise of Medicaid and CHIP directors, supports state programs in continuous improvement and innovation, and optimizes federal-state partnerships to help millions live their healthiest lives. Previously, Kate led the Milbank Memorial Fund's work in support of state executive branch staff and policymakers, as well as its policy initiatives on healthy aging. Prior to joining Milbank, she was the longtime director of health services for Connecticut's Department of Social Services. During this time, she also served as president and vice president of NAMD's board of directors. So a full circle moment. After that, we will hear from Naomi Williams, who will speak to us from her lived experiences as a caretaker of her son, Noah. Naomi describes herself as a perfectly imperfect person on a mission to empower individuals and families to live their best life now. I love that. As a life doula, she helps people navigate and process major life-altering events. Naomi believes anyone and everyone can and should lead an exceptional life. Naomi uses her experiences as a grief coach and yoga instructor to inform her work as an advocate and systems navigator. When not advocating for her family or others, you can find Naomi getting lost, exploring nature, or taking a deep breath on her yoga mat. Oh, love that. So we're in for a great discussion. Feel free to grab your lunch or your work appropriate beverage and get ready to participate in the discussion at the end. And with that, I will hand it over to Amy.
Well, thank you for that introduction, Kayla. Look forward to this discussion here with this amazing panel. Thank you to the Alliance for inviting me to talk a little bit about Medicare coverage of services in the home. We can go to the next slide, or maybe a couple forward. Yeah, the next one. So Medicare service in the home is relatively limited, although definitely an area of growth and excitement thinking forward. But as with most things in Medicare, the benefits are limited and they are prescribed by the statutory and regulatory requirements of the particular benefits. And so historically, there have not been many services available in the home. We'll talk about what they are specifically in a moment. But post-public health emergency, post-COVID, there is growing recognition of the importance of providing care in the home and more flexibility to Medicare beneficiaries about how they get their care and what services they may be needing. Historically, or at least over the past few years, the Innovation Center Waiver Authority was sort of the best opportunity to provide additional services in the home where there's flexibility in those innovation center models to waive some of the requirements of site of service. And so they had tested some models there. And then the other factor to think about is the growth in Medicare Advantage, which we'll also talk about in a moment, but that's changing the landscape for services in the home as more than 50% of Medicare beneficiaries now have these plans and what the services they may be able to offer through that. And so with the next slide, please, can go into a few minutes of the specifics of some of the benefits. And I feel like in the limited time, we will just touch on some of the high level issues here, but happy to go deeper in if people have questions. And so the home healthcare benefit is sort of what people think of with Medicare home services. It's home health care. It is only available to beneficiaries who have meet certain requirements. The most notable is this homebound requirement, meaning that they're not able to leave their home on a regular basis, that they are, in a hospital bed, in a wheelchair, and there's lots of requirements around what that means to be homebound, but generally are not leaving their home, and that they need some level of skilled care. So generally, patients will get these services after a hospital stay, after an accident, or after something that's really changing their circumstance. There are folks who get it on a longer term basis, but the amount of services has to be part-time or on an intermittent basis. So these are not full-time, round-the-clock nursing care. That is something that Medicare does not pay for. I think we may hear a little bit more about what's available through Medicaid, and so if beneficiaries are duly eligible, they may get other services through that. But for Medicare purposes, you're homebound, you need skilled care, and your doctor must certify specifically what you need, whether that's skilled nursing care, so that is, not just care for your activities of daily living. It's something, something more medical in nature. It could be physical therapy, it can be speech language services, occupational therapy. There are certain home health aid services that come along with the benefit, certain medical social services, if it's all really integral to the medical care and some medical supplies as well that come through this particular benefit. Medicare pays them in 30-day increments, and so there's a prospective payment system that establishes the payment rates for these services based upon the patient's need and a number of other factors. And you must get the services through the Medicare Certified Home Health Agency. There are a number of issues with the home health benefit that have happened over the years, the growth in the benefit, the growth in the number of home health agencies. There have been program integrity issues. There have been some other concerns about how it's grown, but use of these services, and certainly the homebound requirement is controversial and has been lots of discussion and regulation and litigation around what that means. And we'll talk about it more in a moment, but that is CMMI currently has a model where they are waiving that to allow more flexibility for the get more access to home health care services. So next slide, please. And so a number of other areas where you can get service in the home. This is what I alluded to earlier about sort of a little bit very specific depending upon the statutory benefit. So telehealth, which we've heard so much about over the past few years, the patient's home can now be an originating site, and through law for 2024, so meaning a patient can receive telehealth services, contact their physician, other providers, if they're in their home to get telehealth services. But historically, before the public health emergency, the patient could not use telehealth in their home, and they would have to be in a rural area anyway. And this, they could be located anywhere. So there is more access for those services. The law also allows for home infusion therapy services. This is through the durable medical benefit. So if you need infusion of certain types of products, you can get that at home. Physician visits can be provided in the home, but not any types of nursing services. So this means that the incident to requirement, but that means the physician themselves, him or herself, can come to your home and provide you with a visit of the services you may need. There are a number of practices specifically designed across the country to deliver home services, but in general, that's not something that physician offices are generally doing these days. And those who who are designed to do home visits are generally focusing on the sicker patients, and that actually leads to the Independence at Home demonstration, which is a statutory program or demonstration that's been extended a number of times. That was a lot encouraging or incentivizing services at home for those practices designed around delivering the care at home. I think there's only one practice left in that demonstration, but there have been higher numbers historically, and some of them have moved on into some of the other CMMI models. And just to go back to the fee-for-service benefits, hospice services also are generally provided in a Medicare beneficiary's home. If you have that, there are some institutional settings for hospice, but generally that is a home-based service. As I said, CMMI models, they have flexibilities built into them that allow for some additional services to be at home. And so I mentioned the homebound requirement. There's what they call a post-discharge waiver, which allows additional types of physician services and incident to, so meaning whether it be a nursing service or something that a physician may get in a physician office to deliver the care without the physician having to be in the patient's home with the nurse or the other providers to provide those services. And so I think that's an area that could be built out further to provide more home services, but also as with many CMI models, or their authority could educate and inform future thoughts about additional benefits. And then Medicare Advantage, they must offer all fee-for-service benefits. So all the benefits I discussed, except for anything CMI related, they must offer as part of their benefit package. But they also can offer supplemental benefits, and that is additional services. You may hear about gym memberships, hearing aids, eyeglasses, dental services, but one of the most popular and fastest growing supplemental benefit through Medicare Advantage is home support services that the plans can offer to provide additional services, medical or custodial, in the home. And you also see Medicare Advantage plans investing a lot in this, both through the supplemental benefits, but also through their acquisitions of providers who do this to help coordinate the care. And you know, as I said earlier, the sort of care generally is not coordinated in the home because there are these specific benefits, but in Medicare Advantage, you can have more flexibility and more coordination of those types of services. So next slide, please. And so want to mention the acute hospital care at home, because this has sort of gotten the most amount of attention recently coming out of the public health emergency, where it's really a lot of excitement and enthusiasm around additional care in the home. And so this was designed to, as it's called, you know, named hospital care at home. So you could be eligible for an inpatient admission, but you as the patient and your caregivers in the hospital decide that you could be appropriate, you know, it could be appropriate for you to have all these services in your home, and the hospital provides the nursing services, the equipment, the medications, anything you may need in your home. And so there have been some earlier tests of this. There are a couple of hospitals who've been doing this for quite a while. CMS this was not one of the very first waivers. It took them a while to create this program. It's not a blanket waiver. Hospitals currently have to apply to it, and along with telehealth, this is one of the provisions that was extended by law through 2024, because there is a lot of excitement and hope for this to be successful. The key issue is the waiver of the hospital conditions of participation, meaning of like what a hospital needs to do to be considered a hospital. And that's waiving the nursing services that are on premises 24/7 and the immediate availability of registered nurse for care of a patient. And that was a major sort of quality component that CMS had to sort of grapple with when they were thinking about, could they make this program work? And so they set up the program, they waived that provision. There are a lot of other quality checks in place to ensure that the patients who are in these programs are receiving high quality care. Couple of things to note about this: Medicare continues to pay the full inpatient payment for these services, even if they're being paid in the home. The question of like, how much do these services cost, or what are the resources needed for them, has not been addressed yet. This was, as I said, created as part of the COVID emergency, so there was a sense of let's test this out, but there probably will be a need to have a conversation about how much Medicare should be paying for these services. And then as of this end of last week on CMS's website, they've approved 125 health systems, 282 hospitals in 37 different states to approve to participate in this. I think the level of utilization varies considerably between hospitals and geographic areas. And one other thing to note, requires a lot of effort on the hospital's behalf to be able to set this all up and to have the technology infrastructure, equipment infrastructure, staffing infrastructure to do this. And so many of these hospitals are using a third party to help them get this set up and be able to deliver the care to the patients. And so CMS is evaluating where this will be, and I think Congress will be looking for information from CMS to see if this is something they should continue on. And then next slide, please. I think this is sort of the last slide in terms of just asking some key questions, as there's a lot of excitement about services in the home, but outstanding policy questions is, how much should Medicare pay for these home services? There's differentials or historically in telehealth services. Currently, there's not they're paying equivalent. I mentioned the hospital at home. How much should that, if you're getting services in your home, is that equal to being in four walls of a hospital that includes payment for other things besides just the visit, the keeping the lights on and uncompensated care and graduate medical education. So there's a question of how much you pay there. Who should be providing these services? Should it be physicians? Are there non-physician practitioners who could be doing it? Does this have to be licensed? as I mentioned with acute care at home, is it can be a third party on behalf of the hospital. Program integrity and beneficiary protection is always it will be front and center, and so CMS will be carefully thinking about those issues to make sure that there's not overutilization, that there's access to services, and more importantly, the equitable access. If you're home-based services, everyone has a different definition of a home, everyone lives in a different type of home, and making sure that all Medicare beneficiaries have access to these same types of services, and that they're getting the best care for them. And then the role of the caregiver. When you bring things more into the home, caregivers take on a potentially higher level of responsibility. And so what is Medicare offloading some of the responsibility onto the caregiver instead of what's been done by historically providers? How do you measure that? How do you ensure that that's, again, back to the equity for the patient and their family? So a lot of things to be thinking about in terms of next steps for care for home from the Medicare perspective. Medicaid has a more comprehensive set of services and been doing this longer than Medicare. And so I'm going to turn it over to Kate to go through some of the key issues on the Medicaid side. But thank you very much.
Thank you so much, Amy, and really appreciate not only the technical overview that you gave, but really that central premise around the constructive tensions that we feel around private funding for these services as compared to government funding, and then really apportionment as between Medicare and Medicaid. So it was a great premise to begin talking about Medicaid coverage of home and community-based services. I will say at the outset, if you asked, an average American, I think their central premise would be that Medicare is the fulcrum point for coverage of home and community-based services. But in fact, that's really a misperception. Medicaid is the central crux of funding for folks who receive these services. And I'd like to illuminate a little bit about the breadth of this coverage and also talk about the why and how of it. So really starting with the next slide, just want to underscore that home and community-based services are a central part of what we think of in aging and disability services as a continuum of supports, a continuum that is a work in progress, but this represents essentially a range of services and supports that span from fully independent living for folks in the community up to very skilled services in a residential setting for folks who have that level of acuity. So a span of services, but also HCBS reflects two very significant strands of advocacy effort over the last 40 years, recognizing that the starting premise, particularly for services covered by Medicaid, was that people would be served in their older years, or folks who had need for support because of disabilities, that they would be served in a residential setting. That has evolved very significantly, as has the kind of guiding precepts of wrapping around folks in a person-centered manner to endeavor to honor their values and preferences and really meet their needs on a comprehensive basis. Again, something that we will continue to progress on over time. The next slide really illustrates the primacy of Medicaid as a payer for HCBS. As I began to say, you see the orange bars illustrate on the left the degree to which Medicaid is the predominant payer for skilled nursing facility services, institutional settings, but you can see that is now dwarfed by the spending and incidence of folks who are served in the community setting through Medicaid, and you'll see the relative bars on these bar charts really do illustrate the apportionment of coverage from other public sources, including Medicare. As Amy confirmed, really that is a small proportion. Significantly, folks are still bearing quite a bit of cost out of pocket, either privately underwriting costs where they do not qualify for Medicaid, or making the Medicare out-of-pocket obligations that are quite significant. And again, there is, I think, pretty poor literacy in the public around this kind of distribution of effort. You can also see on this slide the incidence of the dollars spent, which is very significant. If we can move to the next slide. Medicaid programs have many motivations for covering an extensive array of home and community-based services. And I want to point to this as a rare intersection from a policy standpoint where many people's needs can be met here. I want to first start by saying that alignment of coverage of these services is squarely consistent with values and preferences, particularly as people are going along the continuum of the age spectrum. ARP data continues to support year over year very, very strong preference to remain at home, wherever that, whatever that means for folks, and engaged and connected within a community. This is also of inestimable value for family caregivers. I want to qualify that by saying that this is a very big attention in the LTSS continuum, the degree to which unpaid family caregivers are the fulcrum point of our ability to get people's needs met. And again, the sort of constructive tensions around how much that should be publicly covered through programs such as Medicaid kind of remains an issue. But caregivers do need that support to wrap around their efforts to remain healthy and heal themselves so that they can be the best possible support to their loved one. There are two much more sort of foundational interests for Medicaid programs. First, shifting resources and policy focus to the community side is a way of optimizing federal dollars, state dollars on the whole, although there is really a complex analysis that's needed to really describe this very empirically. The HCBS services are on the whole less costly than institutional settings. And there is an opportunity for states here to kind of marshal resources where people want to be served and also free up the available dollars, the public dollars, for reinvestment in other initiatives like health-related social needs that are emerging as really important means of advancing progress in Medicaid, particularly for folks who lack stable housing, food security. So again, underwriting the cost of HCBS serves really many folks and is this wonderful opportunity that we really rarely see in policymaking. We can move to the next slide. So Medicaid often is described as having a statutory bias in favor of skilled nursing facility care. Strictly speaking, that remains true, and that's been the case since its inception. I have to quickly add, however, though, that since it was enacted, Medicaid has authorized mandatory coverage of certain home services like home health services. Those services are clinical in nature. They tend to be provided by licensed individuals, home health aid services, and nursing services. So they did not really expand to meet the array of needs of a person in the community, and the so-called non-habilitative services that can wrap around both home-based such as companion services, and community-based, such as adult daycare or other community transportation. These are important adjuncts that have been added over time. And again, through the efforts of people who arose as grassroots advocates. Julianne Beckett, an Iowa mom acting on behalf of her daughter who had significant disabilities, was an early example of advocacy in support of expansion of Medicaid HCBS options, as were the plaintiffs in the Supreme Court's decision in Olmstead, which really identified the parity of needs of people with disabilities for Medicaid funded services. So we have a long strand of expansion and development here, but again, that state plan authority tended to focus on that limited array of clinical services. You will see in this chart, there are myriad vehicles through which state Medicaid programs can expand that limited array, and they have done so. Perhaps the most commonly known vehicle is an option called a waiver that essentially enables states to include coverage of services that are not permitted to be covered on an otherwise traditional basis. That can take the form of a specific targeted type of waiver, which is called 1915C, which can enable a state to serve specific populations, older adults, people with physical disabilities, people with acquired brain injury, or a state can take a more comprehensive or research-oriented approach with what is called an 1115 waiver. There's different directions taken by states. Again, this is a flexible orientation that the federal government has permitted to really tailor the approach in a locally relevant way. We also see some emerging opportunities over the last 20 years for integration of care and support to folks through managed care vehicles, managed long-term services and supports, and also integration with the Medicare vehicles through which folks are being served, such as the special needs plans. And I think we are really seeing some momentum over the last couple of years now in really solidifying and deepening those efforts beyond where they have been, which is really around data sharing to encompass a more comprehensive engagement and integration of services. And you see a lot of attention in Congress on the needs of dually eligible folks who form a very significant incidence of older adults and people with disabilities who do receive Medicaid services. So again, an array of options, a lot of technical particulars associated with each, but this has enabled the Medicaid program to surge forward in coverage of folks so that over 50% of folks who require long-term services and supports are now served by one or more of these vehicles. We can move to the next slide. As Amy began to discuss, I think there are some challenges that we're all grappling with as a society and also from a policy standpoint. As she said, that constructive tension over who bears the costs. And again, it's about how much should be borne by private individuals. We recognize, obviously, that these services are extremely costly. Even though there is opportunity for cost savings in the community, those services still represent a significant spend for folks out of pocket. And we don't have any really viable national models for insuring oneself in the way that might be helpful through long-term care insurance. The kind of checkered history of the efforts to do that through the private market that really hasn't taken root in an affordable and an accessible way. Also tensions as between whether Medicare should be the kind of leading edge of the coverage of these services or whether that should remain Medicaid. So that is something that we continue to grapple with. Very significantly, we are facing a historically unprecedented challenge in providing enough workforce to meet the needs of the millions of folks across the country who need these services. And again, a lot of equity matters associated with the women, largely women of color who perform this work, really finally emerging attention to the lack of economic security among folks who are providing these personal care services, lack of retirement savings opportunities, training, really the features of what would make this a viable career path, and recognizing that and really bringing strands of interventions together to address it is really a top priority of all Medicaid programs and many others involved in this field. Finally, attention that I think is also challenging to resolve is that, as I mentioned, states have a range of authority vehicles through which they can cover HEBS services and flexibility about the degree and extent to which they are covering them. In many cases in states that is dependent on appropriation of state funds and also enabling legislation. So there is considerable variance across states, for instance, with the 1915C waivers, the extent to which different populations with different types of disabilities are covered, and constant resource constraints that have yielded in many states situations where people are waitlisted for significant periods of time before they can access services. So again, that is a piece that deserves a lot of attention ongoing in terms of kind of consistency across states and how we can support consumers in understanding the breadth and limitations of coverage. If we can move to the next slide. So I do want to say there's a lot of attention at the present moment in Congress and also at CMS, Centers for Medicare and Medicaid Services, on what we can do to address some of these central challenges in Medicaid-funded HCBS. And as you are aware, CMS earlier this spring issued two major pieces of rulemaking. One is centrally focuses on access to services in Medicaid, the other on Medicaid managed care arrangements. Today, I'd just like to feature a few of the elements of the proposals, the proposed rulemaking around access. You'll see that rule linked here. There's three central emphasis points, just kind of capturing main themes in that rule, which is extremely voluminous. The first is an interest in proposing specific strategies around improving the quality of Medicaid-funded home and community-based services. That takes the form of proposing to adopt a new and comprehensive set of quality measures, enhancements to the process by which people are assessed and redetermined for care plans of Medicaid-funded services, and also new access standards in terms of the timeliness of initiation of services when someone has qualified for and been assessed and approved for them. So all kind of features that CMS sees as materially related to improving quality of outcomes. Also, a big emphasis in this area is stratifying the data that we have available so that we can examine disparities among populations, notably for people of color, which is, we're still at a very naive point of really capturing the extent to which that's the case and identifying and illuminating opportunities to eliminate disparities. There's also a big emphasis on transparency, and you see this through actually both rules, as well as public literacy and engagement. So a lot of requirements for states to standardize and illuminate the rates that they're paying, to really connect people to information about wait lists for services in a much more consumer-friendly way, rather than having folks have to navigate multiple websites and information sources. And also requirements around engaging not only Medicaid members, but community advocates in the rate setting process, particularly for three specified home and community-based services, with the idea that collectively that type of input will improve the viability of those wages and the opportunity for people to be well compensated in this work. And then very notably, the last piece is a new premise around requiring that a minimum percentage of Medicaid payments be made to the direct workforce who performs the services. And this is as compared to the administrative costs that agencies will incur who employ these people, are really a meaningful proposal around addressing those workforce constraints that I discussed earlier. So I'll wind up there, really just to say this rule is open for public comment. I know that all of us have shared interest in really volunteering impressions about that, and CMS would greatly benefit. So urge you to do so. And I would love now to turn to Ms. Williams. We're really looking forward to hearing your lived experience, Naomi.
Thank you so much, Kate. Good afternoon, everyone. I am a Black female with curly textured chin length hair. I am wearing a seafoam green dress that has white and blue swirls in it. I come to you from what was originally Muskogee territory, Indian territory. I live in Evans, Georgia. And I was trying to hide my background, but there is no blur feature on GoToWebinar, which is okay, but I am in a therapy closet. So welcome to my real life world experience, if you will. Next slide, please. Thank you to the Alliance for allowing me the opportunity to share Noah and I's story. And honestly, the best way I know how to do that is through pictures. We are a complex family, but we live a very full life. And there are several intersections with various policies. I know we're here to talk about the home and community-based service policy, but our life intersects different ones. So just want to be able to give that perspective and how we got to this point. For those who, there are a lot of pictures here, and there is alt text. So as you, if need be, as you go over the pictures, it will define the images. In my previous life, before I had Noah, I was a health educator and community liaison for a grant program that worked with high-risk mothers and infants. During my pregnancy, in my second trimester, I began having significant swelling in my feet. And because of my experience in my previous work life, I began checking my blood pressure. And I was monitoring that, and I was sharing that with my healthcare providers, only to be dismissed because I only had swelling of my feet. 2 weeks prior to having Noah, I ended up going to the hospital because my blood pressure was extremely high. It was stroke level. By the time I got to the hospital, it had come down, and the nurse had had a conversation with the physician and came back and asked me if I was a hypochondriac because they don't have patients that check their blood pressure. I was sent home. I followed up with my midwife, and I was started on blood pressure medicine. Fast forward 2 weeks to the day that Noah was born. Prior to him being born, it had been 24 hours since I had felt him move. I went to the hospital. I did not go earlier based off of the interactions that I had had with the previous care providers. So I waited 24 hours before I went to the hospital. While in the hospital, I was monitored for 6 hours before I was transferred to another hospital because they saw a deceleration in his heart rate. I was transferred very casually to a different hospital that in the event that I would deliver Noah, that this hospital would be able to take care of him because I was only 26 weeks at this point. So that's 14 weeks before term. When I get to the new hospital, it had been only 10 minutes. I was being rushed to the OR. They pushed my mom to the corner. They cut my clothes off. They rushed me to the OR. And the last thing I heard before I was put to sleep was the anesthesiologist and the OB that I had never met arguing, where the anesthesiologist was saying, I don't know what her blood pressure is and she could die. To the OB's response, if we don't put her to sleep, the baby's gonna die. Welcome to the introduction of Noah and Naomi's misadventures to life. In this middle picture, you see a picture of Noah when he was born. He spent 153 days in the NICU. Noah is a train wreck on paper. We don't shy away from that. We share that. And he is not that paper. So as you see on the slides, we have had a lot of medical experiences. We've had a lot of near misses. I've said goodbye to him twice. I've had to say allow natural death twice. And with that, on the other side of the screen, you see where he is in an ATV with a lot of things around him, surrounding him, but he's driving and he has a huge smile on his face. And my shirt does say, I saw, and I made it awkward, which I do. We do not shy away from hard and uncomfortable conversations. We live our life to the best of our ability, the good, the bad, the ugly. We make it the best life that we can. Next slide, please. So with that, just to give you an idea, I told you I'm here at Noah's Therapy Center. An idea, bring you into a day of the life of Naomi and Noah. On the right-hand side, you will see a list of daily medications that Noah receives. Just about all of these he receives twice a day, and this is not his full extensive list. These are just the ones that he gets every day, not his as-needed medications. On the left side of the screen are his diagnoses, and I purposefully did not spell out all of the abbreviations. One, because I am still a health educator and I want to encourage you to learn about our world and to see what some of these diagnoses are. I told you, no, it's a train wreck on paper. So you can go and see what some of those things are. as well as this is the introduction that parents get. We get talked to a lot of times in abbreviations and we have no idea what they are. So we have to go and learn what it is so we know how to best advocate, not just for our child, but for our family as well. And then in the middle, down at the bottom, there's a list of his active specialists that he sees. These are not all the specialists that he has ever seen, but they are the ones that are part of his current care team. And only 2 of them on this list have we been able to go to seeing them once a year. Everyone else, we still see them 3 to 4 times a year. And what might be most prominent or startling to most is the picture that is in the middle. And this is a care map that I created in 2019. I am not the originator of this idea. This came from another mom from Massachusetts, I believe, Mass General. But it's a great way, it's a great illustration to show these are all of the people that I have to interact with that Noah is connected to in order for him to have the life that he has. It's a lot of people, it's a lot of moving parts. If you'll go to the next slide, please. And so just wanting to give you an idea of what a day in the life for us looks like, and that's what that previous slide was. So how did we get here to being able to have a home and community-based service waiver? Noah is actually receiving what's called the COMP waiver, and I'm very thankful for it because it has truly enhanced both of our lives. And the pictures that you see here, the one right in the middle, he has, we were able to adapt our home and have an accessible roll-in shower. And you might see some little feet that have red socks down at the bottom. And that's him on a shower, an adapted shower and potty chair. So I wasn't gonna show him doing all of his stuff, but the waiver had enabled us to modify our home so he is not relegated to having a bed bath only. He's able to go into a shower and actually able to use the bathroom. That's pretty significant. The waiver also enabled us to be able to modify a van to make it wheelchair accessible. Noah does not walk independently. He is wheelchair dependent. And he got to a point where it was difficult to be able to lift him and then lift his van into a regular size vehicle. So the waiver enabled us to, it did not pay for a van, and it did not pay fully for the modification, but it helped us offset the cost. In this picture, you can see us, we're overlooking the lake as the sun was setting. Some of the other things that it has enabled us to do, Noah was able to go to have a typical kid experience, which was going to an overnight camp. He spent 5 days at this overnight camp and he was able to get on a horse. It was something I never thought he would be able to do, not just get on a horse, but to be able to go to overnight camp based off his medical complexities. The waiver enabled him to do that. They were able to pay for that for him. It helped us send him to art camp, a local art camp. It is not a special needs camp. It was an art camp and we had an amazing instructor and caregiver that were there to support him and see him for who he is and work with him to discover his talents. And from that, he is an amazing abstract artist, and thus Noah Land Art was born. It also enabled him to begin doing yoga therapy. He has a lot of respiratory challenges, and yoga has been amazing. It taught him how to breathe. And so being able to work through learning his body, what he has control over, and teaching him new things to help him live to the best of his ability. And last but not least, the waiver has helped me be able to continue working. There's a picture down here. I used to work as a family support coordinator at our local children's hospital. I was able to go back to work part-time and assist and help families navigate systems just like I do in my everyday life. But the waiver enabled me to get caregivers to be able to be with Noah because there's no daycare that would accept him. And as great as the waiver has been, we have and continue to run into some challenges. And I'm ever so grateful for our community. There's a picture here of 4 young men in front of our home, in front of the ramp that they built for us. There were a lot of loopholes and hoops that I would have had to jump through to be able to get this ramp with waiver funds, and we just didn't have the time or opportunity. And so our community stepped up, and Rob Gates and his sons and a friend built this ramp for Noah, and I wasn't able to compensate them. However, we are eternally grateful because now Noah is able to get into the house. So with that, if you'll go to the next slide, please. Just wanting to be able to share, I know this was very fast. I look forward to the question and answer segment, but this is Noah in his bedroom wearing a green shirt that says "My Life Matters." And it does, because I'm sorry, not sorry that if I cry, this is my life and it's emotional and it's hard at times in sharing some of these things. So if I do cry, I am okay. Just know that. This picture shows his life matters, and individuals and families like mine, our life does matter. And one of the conversations that we are not having enough of is about neglect, abuse, and filicide. And filicide is where it's murder, suicide, where parents kill their child and then kill themselves. The top 3 headlines here are from Georgia. The top 2 have happened in 2023. And then the last one, I'm wanting to show this is not just a Georgia problem, this is a national problem or challenge that we need to have discussions around. And part of that leads into how do we take care of the caregivers, as well as how do we take care of caregiver being parents, as well as direct support personnel to where it's a livable wage, to what Kate mentioned as well. So that is a quick down and dirty overview of our life, and I will turn it back over to Kayla.
Thank you so, so much to all of our panelists. And this was an incredible overview. Thank you, Naomi, for sharing such a personal portion of your story. I can't imagine that this is the full story, and that there have been, I imagine that there are so many challenges that you brave every day and every moment, just living this. So we are so grateful for you being here and sharing some of your story with us and allowing us to learn and be inspired by you and by the work that you're doing. So if we can have our other 2 panelists join us, we are getting some great questions from the audience. And if you have a question, feel free to ask it. We have a little bit of good time for some good conversation. So feel free to put your questions in the chat. And I will kick it off with an audience question for, let's see, I think this one we'll ask Amy. If there are any Medicaid funding opportunities for home evaluations of competency for folks who need testing but are homebound or not able to leave their homes.
I'm sorry, for Medicare or Medicaid?
For Medicare.
Okay, for testing. So I'm sorry, can you say that again? For testing, if they're.
So yeah, are there Medicare funding opportunities for home evaluations for other, in-home, I believe, testing to see if they qualify, I assume, for these services, and other things for people who are homebound.
Yeah, so there's the Medicare home health benefit, but a number of there isn't a specific Medicare benefit per se for that, but a number of like accountable care organizations or Medicare Advantage plans will go into the home and look to see if what kind of services a Medicare beneficiary may need. There could be things that they may be offering like to prevent falls or other services that they have, but not a specific, they don't, there could be durable medical equipment that someone can need, a hospital bed, wheelchair, things like that, but not the sort of ramps or grab bars. Medicare does not pay for those specifically. There are, like I said, there are some folks who will do an evaluation for that, and then the specific Medicare Advantage plan or accountable care organization may choose to pay for it, but as a broad benefit across the board for everyone in Medicare, there aren't those services available, at least right now.
And can you talk a little bit about the hospital at home program and how that might continue to grow, or if that would, how that relates and interacts with home health benefits?
Mm-hmm. So in order to be eligible for it, you would have to be needing an inpatient hospital stay, often for something like congestive heart failure, COPD, really something more on the medical side, not surgical. And then if your hospital is participating, you as the patient and your doctor sort of would have the conversation of, are you, is this something that you feel comfortable doing? Do you feel comfortable having people come into your home? Do you want to be at home? And then you would agree to it. And then you and the hospital would sort of make all the arrangements for the specifics for what you need, but it's still inpatient level of care in terms of, the treatment you need. And then when you're no longer inpatient eligible because you've recovered, you would then could potentially get other services. Although this is not a program right now, a lot of people are talking about SNF at home, skilled nursing facility level of services in the home. And so that is a potential area for growth. But the growth areas in terms of the current program, which would run through 2024, would be the facilities that can provide it. It's generally, these have been in more urban areas because of the ability to get the equipment to the patient, because these are short-term stays, and so they need to get there in a very short time, matter of hours, to provide these services. And then also having the workforce available to support what's needed, and the technological infrastructure, because so much of at the hospital at home is dependent upon that sort of two-way communication and the telehealth services that are available. So there are, as I said before, there's companies that are helping to facilitate this, and there's opportunities for growth there. And the hospitals themselves have to want to be able to do this. And so it will be, up to Congress or, CMS to decide if they want to continue this program sort of as a standalone program, that they want to continue to have it as that you have to apply and meet certain quality measures. And so there's that. But then also, as in terms of mentioned, the SNF at home, there is is there a possibility for offering more continuum of services in the home, even if the patient doesn't need that hospital level of care?
Thank you. So as Kate mentioned earlier, Medicaid is the primary payer for HCBS. So Medicaid is a very influential stakeholder. And to that end, CMS released, and as Kate also mentioned, it's accepting comments on 2 proposed rules in Medicaid on access and managed care. And the access rule contains many of the HCBS proposals, including new requirements for person-centered planning, reporting, quality measurement, as well as the more publicized proposal to require that at least 80% of Medicaid payments for personal care, homemaker, and home health aid services be spent on compensation for direct care workers, as opposed to administrative overhead or profit purposes. So I do want to talk about that 80% threshold, but first I want to talk about the people that actually make up the workforce. And what we know that of these people is that most often they are women of color who have immigrated to this country and are earning a median of maybe $12 or $13 per hour. And we know that there has long been a shortage of workers available to even provide the services, and that was significantly exacerbated by COVID-19. So a lot of things going on here. And since we have your expertise, Naomi, I would love if you could just tell us a little bit about your experience really getting paid as a caretaker to provide these services, and what it was like for you to become an eligible provider to help your son.
Thank you for that question. So I am an unpaid caregiver. I do all the work. I am an employer, so there are different types of, with the specific waiver that NOAA has, that you can either go traditional or what's called participant direct. And traditional, you have an administrator, they have staff, they have the overhead, they have benefits, all of that. As a participant direct, I am it, or there's what's called an administrator, but that administrator is unpaid, but still required to handle all of the things as an employer. So I find the staff, I train them, I hire them, I fire them, I set their schedule. I have not had to fire anyone, let me say that. I'm really good at my picker is pretty good. So I work probably a good 40, 50, 60 hours as administrative. That's not including taking care of NOAA. That's not including working my jobs as my contracts and being a consultant. So I am not paid. And then when you talk about the caregivers, the reason I chose to do participant direct, people may say, well, why don't you do traditional? One, there are no traditional providers in my area that will do a minor. Hold it together. So I don't have a choice in that fact. And then choosing to do participant direct, when NOAA becomes 18, then I can look at going traditional. But also doing participant direct enabled us to have more access to the funding of his waiver. So he has more money if I administrate it than a traditional provider, because there's no overhead, quote unquote, overhead with me. So I'm able to pay his caregivers more than a traditional provider. However, it's still not a livable wage.
Wow. Everything you say is going to take my breath away, I think. Just what I'm hearing is, besides the passion in your voice, is that there are a lot of nuances to your story, and that what I know, at least from working in Medicaid, is that it always varies by state, and I'm hearing that it varies by population. And so, Kate, I'm wondering that I know some states do have a similar threshold, or a threshold of requiring a certain amount of payments to go directly to workers, but I was wondering if they have data that is available to show what they do pay in general, and where, or if other people can access this data, we can know how much states are giving to providers and then how much the workers are actually getting.
Yeah, I deeply appreciate that question. I wonder if I could just for a moment, though, really honor what Naomi said about the choices that family caregivers are put in the position of having to make on a day-to-day basis. The parameters of the coverage have evolved over time in just the way that you said, from a point prior to the 1980s, where there really was no choice other than to work with a licensed home health agency. That has evolved so that much more opportunity for self-direction of services is now permissible in almost all states. That said, I think there still remains some tensions about paying family caregivers, sort of a socially embedded premise in our society that women are expected to do this work. And I think that that's something we really have to wrestle with as the family dynamics, the geographic distance amongst family members, obviously all prevent tremendous strains. And also you can hear, Naomi, the exhaustion and the pain this has caused you, and just in terms of balancing all those factors for yourself. So we always describe self-direction as this amazing evolution and improvement in Medicaid, but it also comes associated with everything that you described, and I'm just deeply conscious of that. And even to the extent that Medicaid programs are able to pay for family caregivers, as you were seeing, Keila, there has not been a nationwide standard for the extent to which there's a pass-through of a specified percentage of the reimbursement dollars, so that people are assured of a meaningful, viable wage on an hourly basis. So your question was about experience in states. There are a small set of states that have moved forward on their own initiative with a minimum percentage pass-through. Some of those states did essentially wage analyses, looked at their individual circumstances economically, regionally, and it is principally leaping off the experience of those states that CMS has proposed the 80% threshold as a uniform national standard. I will say, I think states think of this as a very positive step to propose a minimum. There is some range of opinion about 80% and about potentially building in some exceptions, for instance, for small providers in rural settings who may have higher administrative costs, for small businesses owned by folks of color who may need to buy those administrative services. So we will be commenting to raise some of those scenarios and urge CMS to take a permissive posture with some of those aspects. But again, strong support, not as much evidence-based as I think we would like to see nationally, and that we hope will develop with implementation of the standard.
And do you think that states, well, actually, let me back up, because I can only imagine that states are also dealing with a lot. So would you be able to tell us kind of the world that states are living in addition to thinking through what's going on with HCBS and responding to CMS and these pretty broad, to letters, but I also know that there's COVID still happening and going on. We're still coming out of COVID, and that states are doing a lot of redeterminations, things like that. But can you level set kind of what states are prioritizing right now for us?
Absolutely. And, as we all experience, the COVID-19 pandemic was just a maelstrom of urgency, illuminating in so many cases long-standing needs, urgent needs, and disparities that I think Medicaid programs are uniquely situated to address. So you saw, obviously, programs pivoting so rapidly to try to respond, from the standpoint of preserving access to covered services through telehealth, the many flexibilities that were afforded by the federal government around where people could receive services and who could provide them. I think a lot of the learning that we had from that was so instrumental as we're emerging from the formal end of the public health emergency in terms of what can be embedded ongoing. So telehealth, centrally proven as a major enabling feature. I think states are going forward with that. Less clear are some of the flexibilities around home and community-based services. And again, that aspect of paying family caregivers, I think you see significant variability across states. But that's a piece that states are really looking at, is to what degree to hold on to and make permanent the opportunities that we had during the pandemic to just think creatively and meet people where they were at that time. I think another central proposition this year, as you mentioned, is really bringing all states into compliance with eligibility standards at the federal level that are designed to smooth people's access to Medicaid eligibility and then maintain continuous eligibility. That's a big area of focus for states this year, as they have been charged with Congress with redetermining the eligibility of every single of the almost 90 million people who are served by Medicaid principally. So that piece, and CMS absolutely looks at these access and managed care rules as companions. So not only do we want to make sure it is simple and straightforward for folks to access Medicaid coverage and remain covered, but really make it a meaningful meaningful benefit in terms of accessing services and also examining and improving quality and parity of experience across various coverage groups.
Thank you. And speaking of COVID, Naomi, I was wondering what some of the shifts have been that you've experienced going through COVID, coming in and out of it, if there were certain flexibilities that were helpful during COVID or certain things that were more challenging, or things that you're looking to the future that you're preparing for as we're coming out of COVID?
I would say both and. So the good things that came, I tend to, COVID was hard. It was hard for all of us. It was extremely hard and decimating in the disability community. We are typically a forgotten community, and it was exacerbated during COVID. With that said, we learned that there were workarounds to be able to help families like mine. And some of those things were with the telehealth. That was huge. And that's something that we are hoping that will continue and will stay. The family caregivers being able to be hired and that is something that we are hoping that will stay. There are provisions, so I would not be able to be a family hire unless I had someone who would be an administrator of NOAA's waiver.
Mm-hmm.
But for families who have that, where there are other people in the household where they could make that work. So that is something that it worked, and we hope that stays. Another was where individuals could be served outside of their home. That's huge, as otherwise, the way it's set up right now, our home is the institution. You move outside of a community institution or a hospital, and the home, because the services have to be provided in the home. And so through COVID, there were some provisions to where services could be provided outside of the home. Without getting into the nitty-gritty of the different codes, some of the things that were challenging and that still are is not everybody has benefits. And so now I have to compete with fast food. I have to compete with big box stores for wages. And because Noah is a minor and he's in school, his budget, I'm figuring it out of how to keep the help that I have to make it attractive enough. She loves my son. That's why she's still with me, because what I can pay her is not enough. So the direct support pay is a huge challenge. Not being able to have benefits. There are things that my state has not done Medicaid expansion. When Noah was on the waiting list at 4, there were 6,000 people on the list. There are over 7,000 now, and our state's budget could fix that, and they're choosing not to.
Can you remind us how old Noah is now?
He just turned 14. He just had a birthday.
Amazing. Happy birthday. Please tell him we all say happy birthday.
I will. And I will just say, when you talk about the access and information, families, programs are as good as the information that gets to the families that need them. And it's how do families get that information? So a lot of what I know has come from other families. It's not coming from those that are instituting the policies or the organizations and programs that are making these decisions and overseeing what my family should or shouldn't have, that's not where we're getting the information. So the access, if I was not an advocate, Noah would not have his waiver now. I was told at 4 to wait until he's 18 to apply. Because that's when he would get it. I said, well, if for some reason the state has a windfall of money, if he's not on the list, he will never get it. Then the very next year, there were some changes. There were some changes with Noah. There were some changes with me. There were some changes in the state. He was able to get the waiver.
Wow.
There are families that sit on the waiting list 10, 15, 18 years.
Wow. And even, I mean, yeah, you are going to have us all just crying together. So even with that, I am drawn, and we have an audience question that people are worried about, you know, the Noahs that don't have you. And we're wondering about people who receive HCBS elsewhere, maybe in public housing. So I don't actually know. Do either of you know, any of you know how many people receive HCBS in public housing authorities? And I know that it varies by state, but I'm not sure if we even know that, to the point about needing more data.
Yeah, I have to say, I don't know of a public source that illuminates people's settings to that extent. Folks are in all kinds of settings. So they're in publicly supported housing, they're in supportive housing, they're in private apartments, they're in group living arrangements. I mean, the span of the HCBS settings is very considerable. And there's been a lot of work, as you know, Kayla, in the last several years, making sure that folks in those settings are truly integrated. There's a major rule that was released by CMS that asked Medicaid programs to review each and every environment in which people received home and community-based services and make sure it was not siloing people with disabilities, not treating them, as Naomi said really powerfully, as though they're institutionalized in their own home setting, that they have a chance for meaningful rights and opportunities and integration with communities. So that's something that all states are also focusing on.
Mm-hmm. And I wanted to take some time to look forward and think through some of the things that are enabling growth. And I know that there are things we're hoping to address some of these wait lists and things like that. I'm wondering about technology. And if Amy, if you know of any innovative models or technological advances that are enabling growth in this area, or that we're looking toward and hopeful for, you know, for HCBS improvements?
Kate, do you want to talk about the HCBS specifically? Then I could go about Medicare.
Yes, specifically HCBS. If you want to broaden it to Medicare, I'm sure we would all love to know.
I'm not as familiar with the HCBS, so if Kate knows something specifically there.
Yeah, so I want to defer also to Naomi. I hope would talk about what she feels is also needed that we don't currently cover. But I would say Medicaid programs are increasingly covering remote patient monitoring, which is a means of essentially supporting folks in independent living, where folks who have conditions that would benefit from support from someone who's a nurse or other clinical professional could be, associated with that help, and still live independently. So that is not the case in all states, but it's kind of growing. I also really want to credit advocates for folks with intellectual disabilities have really promoted approaches like smart home, so environments, accessible environments that essentially wrap around an individual with disabilities and make it easier to live at home, as opposed to asking people with disabilities to conform their behavior. It's really bringing the environment along. Naomi talked about the home modifications that are covered by Medicaid. Again, still some administrative challenges there, as she described, and I think that is something we can improve on. And finally, I do feel like all programs across the country have proven the success of the use of telehealth. All programs are making a substantial set of services permanently available through telehealth, not only through video conferencing, but audio only calls. So folks in remote areas, people with disabilities who may require technology accommodations, all those folks could be well served in that way. And I do think that Medicaid has moved a lot faster than some other payers on those things, and especially paying at parity for some of those services, which is something that kind of remains a tension for payers in general.
And Naomi, do you have, oh, I'm sorry, please go ahead, Amy.
Oh, sorry. I was just going to say similar things, at least on the medical services side for Medicare. The remote patient monitoring, Medicare now pays for. There's particular requirements around it, but it does allow physicians to really keep track of their patients, whether it be weight, blood pressure, other things to help manage them, keeping them in the home. Telehealth, absolutely. And I would say, we sort of, I think, alluded a little bit to the different places people call home, and there's a lot more focus in nursing facilities of Medicare beneficiaries in nursing facilities, where oftentimes they had a hard time, seems kind of counterintuitive, but a hard time getting medical care, and the facility would often send them directly just back to the hospital because they couldn't be equipped to it. But now with more of the technology, more of the telehealth, it allows physicians, nurse practitioners to be able to provide that care and help manage some of the care, so the patient isn't always shuttling back and forth between the nursing facility and the hospital. It really keeps them in their home, which is the nursing facility. So there's a number of examples of things like that. And I think it's also a rapidly evolving area. So if we were having this conversation in 6 months, there could be a whole variety of other services as well, and more innovative ways and thoughtful ways of being able to use the technology that exists to deliver the care to the patients in their home.
I know, and we only have a few more minutes, so I do want to, I think, pick up right there. I want to think about the next 6 months and the ways that we can try to help, move the needle. So Naomi, do you have any recommendations for policymakers, for other stakeholders, for people that are advocating, anything that you can tell us to put a little of you inside of all of us?
Yeah, my two things would be, as simply as I can say it, is there is a person attached to the policies that are being put in place. So whether it's the paperwork or as you're thinking through, remember when you're about to make a decision, I hope Noah pops up in your face, or I pop up in your mind. How would this affect them? It's not just theory, it's how will this impact someone down the line. And the other is, nothing about us without us. And what that truly means is bring a Naomi in, bring a Kyle in, bring a Nandy in, and at the beginning to be a part of the conversation, to give real life experience of, yes, this could work, no, this couldn't. I don't have a behavioral challenge with Noah, but there are many families that do, and behavioral supports are significantly lacking with waiver services, the way that they are provided. And so bring us into the conversation. We are subject matter experts, degreed or undegreed.
Beautiful. Amy, can you give us some recommendations for how we can help Medicare help us?
Yeah, I mean, I think it is the demonstrating that the value of the services to the Medicare beneficiaries, and what the opportunities are to keep people allow them to be where they want to be, to age in place, to get services, to be thinking creatively about how to deliver the care, and that just thinking about the hospital at home, that patients can be really sick, but they're still, with the technology, there's a lot of ways to continue to treat them and ensure there's more quality. So thinking about that continuum of maybe they're not trying to keep them from being inpatient eligible in the first place with additional services in the home. And I think as been said, it is the hearing from the perspective of what works and what the Medicare beneficiaries want in their perspective as well, and what's important to them, and designing policies around that. Medicare, we often focus so much on the provider side, but really, keeping the Medicare beneficiaries front and center as well about sort of what their needs are and what makes their lives easier as they age.
Absolutely, thank you. And Kate, how can we help states, and how can we support them, and how can we advocate with and to them?
So I too want to just affirm what Naomi said. I think that the most powerful means of advancing Medicaid coverage of home and community-based services is starting from the perspective of the people who receive them. Naomi, you're a powerful witness to that. You are uniquely qualified to talk to where systems, however well-intentioned, do not work in the way that is wrapping around what you need, you and your son. And the longitudinal data we have that illustrates not only the opportunities for meeting people's preferences, but also cost savings, is only amplified and made relevant and powerful when it is linked with personal narratives of that kind. You are a powerful emissary for that. I think back, as I mentioned at the outset, thinking about the origins of the Medicaid waivers. Julianne Beckett, as I said, an Iowa mom of a daughter who had significant disabilities, worked channels through her congressperson, ultimately was successful in persuading then President Reagan to give special permission for Medicaid services to be used in the community. That did not arise because of statistics or legislative advocacy on a formal basis. That was the power of story. And I personally am so focused on that aspect, how we continue to share that, especially with policymakers who may, despite the incidence of family caregivers being extraordinarily high, just not have had that experience in their lives. So that's a piece I just say, amen to that, Naomi.
Amen, amen, and amen. Thank you all so much. Unfortunately, that's all the time we have, and we had a lot of questions still, a lot of audience participation. I promised a riveting discussion, and I think we did not disappoint. So I want to invite Chris back, and thank you all again so much for sharing your time and your energy and your space with us. And thank you to the Alliance, especially for including and being very intentional with who they chose to have on this panel, and for giving us the beautiful benefit of having Naomi's experience and knowledge. So thank you so much, Chris, and the rest of the Alliance.
Great, thank you, Kayla, and thank you, Amy and Kate and Naomi, for joining us today. It was a wonderful discussion. I was really enjoying being able to be kind of on the back end of it with you all. So thank you so much. And then for our audience today, let me just take a minute and ask you, later today, you will be receiving a brief evaluation survey via email. Please take a minute and fill that out. It really helps us as we design future programming to know what worked for you and what didn't. So we appreciate your feedback there. We have a lot of public webinars and in-person events throughout the year. In particular, if you follow our LinkedIn page or visit our website, you'll find information on our upcoming Signature Series events on envisioning a patient-first health system, so look for those. And then a reminder that a recording of this webinar, Recent Trends and Policies Impacting Medicare and Medicaid's Home and Community-Based Services, as well as additional materials, are going to be available on our website. That concludes today's webinar. Thank you so much for joining us today.